by Bereni in 1921, and the diagnosis for diagnosis the test maneuver was described by Dis and Hallpike in 1952. Pathology, the first description was by Shuknik and Ruby, known as cupular lithiasis in 1973. And Hall was first to describe the particles in the canal, not in the cupula. Not too late, within 6 years of first description of the particles in the cupula. And Aplis gave the name as canal lithiasis to this condition, particles in the canal, in 1992. What are the types? Commonest is posterior semicircular canal, less commonly lateral canal, and of course we do see rare cases of combinations involving both of them. Diagnosis is mainly clinical. So again, we'll go back to the history. History is very, very important because, as we say, as I said in the beginning, it's a positional vertigo. It always comes in same position. You keep repeating the position, it'll keep coming. But if you do it immediately, it fatigues. So history is very, very important. And diagnosis can be confirmed by Dix-Hallpike test maneuver. Sometimes, if there is a doubt, then only the investigations are needed to rule out other conditions. And they can be audiological investigations or vestibular evaluation. Now, what we do in the Dix-Hallpike test is we give provocative position, the position where patient gets vertigo. There is a slight delay, so there is a latency before the patient feels dizzy or nystagmus comes. There is a typical nystagmus that depends on which canal is involved and what side. It's transient, it disappears. Of course, all the patients, they get vertigo. Some of the patients do not get nystagmus. We will come to that why. If we reverse the position, what is done in the test maneuver, nystagmus may reverse. And as I said, it's fatigable. So if you repeat it second time, the patient doesn't get as much vertigo as the first time, and if you do it again, he may not get it also. Now, actually, this is actually I just shown how to do the Dix-Hallpike test maneuver. Do you want to see it? As most of the people should know it. Okay, so sorry. So what is done is the patient is in the sitting position and head straight. We check for the nystagmus before we start. Wait for a minute in each position, and then what we do is basically is tell the patient to lie down, supine position with head extended and turn to the opposite side of vertigo. So first time you always do on opposite side. The reason if patient feels dizzy immediately, then they are not so cooperative. And always explain to the patient that you're going to feel dizzy and it's going to be transient. So don't worry about that. What is happening? Okay. So sitting position, head straight, explain to the patient, one may feel dizzy and find out which side patient is feeling dizzy and turn the head to the opposite side. So extend it and turn to the one side 45 degree, both. 45 degree extension and 45 degree turning to the one side. Again, patient goes back to the sitting position and again head straight. Again, you can check for the nystagmus. If it is, as I said, it can be in opposite direction. And second time when we do it, the patient is head is turned to the side where the patient is getting the vertigo. Sorry. One more thing I do before checking the patient or seeing the patient also, I always tell them to stop the medication what they are taking for vertigo. The reason is, if they are taking any kind of labyrinthine sedative, while doing the test maneuver, they may not get vertigo at all. So you won't be able to diagnose it. Is it a BPPV, number one, and which side is involved and which canal? What are the treatments? There are medications. We used to do vestibular rehabilitation, surgical, single needlectomy, postcanal occlusion. Of course, now the only treatment, I will say now the only treatment is particle repositioning maneuver. Now, how is it done? Before doing it, we have to make sure we do not create a new problems. So make sure the patient doesn't have very bad neck and the back problems, uncontrolled hypertension, perineal fistula, because if you move it suddenly, then it increases, and retinal detachment again is related to the sudden movements. All these are relative, so if we do it slowly, we can manage, but if we know it, how bad they are, then we can be careful, or we may not have to do it. Now, how I do it, actually, I use a model which has headband, and there are models of or replicas of the semicircular canals, 3 semicircular canals on each side, which we can see and placed above the ear, the same level as the semicircular canals are. So every time we move, we will see the particles moving. So we know we are given a right position. So this model is not for the diagnosis. This is for giving the right position during the particle repositioning maneuver. It started, the treatment or a particle repositioning maneuver started same way as we do the leg salpike test. So first is sitting position, wait for a minute, and then tell the patient to lie down supine, head turned to the side where the patient is getting vertigo, or which we have checked it by disc salpike test. Sorry, again we have the same problem. It's going to play or no? Just a minute. Okay, so supine position, from sitting position to supine position, head turned 45 degree to the right and extended. And then we'll see the canals where the particles are moving. This is the posterior canal, this is the lateral canal. This time we are doing a particle position maneuver for the posterior canal, right posterior canal. You can see the particles are moving from ampullary end to the dome. And the next step, we turn the head, only head, 180 degrees to the opposite side. And you see the particles from the dome, they are moving to the non-ampullary end. Here, they already moved to the non-ampullary end. The next step is turning the whole body to the opposite side of the vertigo. So patient is lying laterally and head is facing to the opposite shoulder and extended. In this situation, what happens is the particles go inside in the utricle. And then I made the patient sit. Originally, what Aplis had described as the last step is head bending forward, where the particles are supposed to be going to the utricle canal so that they don't come out. I haven't found any difference between that doing it or not doing it. And here we can see the particles have moved from the ampullary end of the posterior canal to the non-ampullary end. Now, lateral canal is less common, and the commonest reason is secondary to the particle deposition maneuver of the posterior canal. Again, it's a self-limiting condition, and treatment again is particle depositioning maneuver, a different kind, not the same one. Here again, what I use is the model. The difference is here the patient lies supine and is not neck is not extended, just turned to the side, and then it's a log roll, what is known as, and just keep moving the patient by 180 degrees. Again, to the opposite side of the vertigo. The patient is getting vertigo on the right side, then turn opposite side. The rotation is on the left side. Lateral canal, the particles are moving from the ampullary end to the dome. So head is turned to the opposite side. The particles start moving from the dome to the non-ampullary end. There are other procedures described in the literature, but these two I have found is the simplest one, and to do that, model can be used for any of them, and it's just the guide to give a correct position. Another thing which the model helps in the waiting for long enough, which is the commonest reason of failure of the particle depositioning maneuver. If you don't wait for long enough, the particles, not all the particles have gone down or to the opposite side or inside the utricle, and the patient gets recurrence of the symptoms. Then, of course, is a prone position, keeping the head in the same position, so turn to the left. And of course, the last step is again supine and sitting. Now, in beginning, when Epley's first described it, he has given so many instructions to the patient to do it. And he has used a lot of other precautions before doing the maneuver. He used to give them some sedative so that the patient doesn't feel dizzy, and he has described to some people, patient used to vomit also. Most of the times, it is not severe enough to give dizziness enough to cause vomiting. So I haven't found that useful. I never use it. So normally I do it when the patients already stopped the anti-vertigo medicines. Similarly, post-op, he used to give them so many instructions to follow, which again I'm not using it at present for quite some time now. The only thing which I tell them is head up position for 2 nights, and it's not very high. If you remember it, when we did the maneuver, it was extended neck. So what we use a head up position is the neck is flexed, so that we are not reversing the whole maneuver in a sleep or unknowingly. Same thing can happen while doing a neck exercises, and basically avoid head neck extension. This is what the basic principle is. Failure. If we do not give the right position and we do not wait for long enough. Of course, Please has described also the fixation of the particles, which is described how to handle it. They just use the tuning fork, low frequency tuning fork, and put on the patient's head. And I have tried that on the model also, because sometimes you try to move the particles very fast, they get stuck at one place. Just tap the model, starts moving. The similar thing, what can be done in the patient is to use the tuning fork, put on the patient's head, and the particle starts moving again. Wait for longer in those cases. If the particles get stuck in a cube, ample reason, what happens is the patient gets severe vertigo, or in the middle. So what you do is basically reverse it and wait. It settles down. We know that is a temporary thing. Reverse migration. So by mistake, if you give a wrong position, the particles move from non-ampullary end to the ampullary end. And of course, one of the complications is conversion to the lateral canal, and we have described how to correct that also. Some of the conditions which can present at benign peripheral positional vertigo or which give positional vertigo, we have to be careful about them, which are recovery phase of manias, some of the migraines, post-TB surgery, labyrinthine fistula also can present that way, vestibular neuritis, transient ischemic attacks, and of course some of the tumors. Alcohol. So we have to be careful making the diagnosis. If the diagnosis is correct, the particle depositioning maneuver gives very good results. And if the diagnosis is not correct, most of the patients who do not recover after doing a maneuver, what I have found is the diagnosis was not correct. Very few patients, they need the maneuver a second time, which normally I do it after a week. Some of the patients, after the maneuver for a couple of days, they may feel slightly unsteady. They do not get positional vertigo, but they do feel little unsteady, and suddenly it disappears roughly after 48 hours. Thank you.